Thank you, Dr. Bala, for the very warm welcome. And again, as you said that, it is an important topic which we do encounter, especially a patient of RTA and a lot of other patients that come to us with brain injury, maybe acute, mostly acute conditions, specifically when we talk about critical care scenarios. Then what exactly is the line of approach and management? Let us go and, unlock this topic one by one. So in this, we'll be discussing about the definition. What is traumatic brain injury? What are the causes and pathophysiology of it? We'll be talking about the severity, diagnosis, complications, and management that are being associated with TBI or traumatic brain injury. So traumatic brain injury is basically defined as an insult, and that insult is there to the brain. This insult is not because of the degenerative and congenital nature of the brain, but it is because of the external physical forces. And because of this, it results in either impairment of the cognitive abilities of the patient or impair their physical functioning. It can also lead to disturbance of the behavioral or emotional functioning of the person. So when we talk about the causes, specifically when we talk about RTA, and if you look at the data in terms of Indian scenarios, every 5 to 10 minutes, there is a road traffic accident in India. So this is the general data which has been presented by the Ministry of Road Transport and Highways. So every 5 to 10 minutes, because of that RTAs, because of that delay in, getting a proper medical attention, it leads to, of course, brain injury, and thus, survival chances, increasing the mortality, morbidity are more common. So an outside force that impacts the head, causing the brain to either shiver or to move. It can be either because of the physical forces, maybe a direct blow to the head because of any stick, rod, or any kind of thing, or a rapid acceleration and deacceleration of the head. For example, if the patient is sitting in a vehicle, if, for example, there is a sudden brake applied to the vehicle, so you see that if the vehicle is moving at a speed of maybe 100, maybe 120, and a sudden rapid application of the brakes causes the person to fall forwards, and because of that, there is high chances of patient getting a knock with the dashboard or with the wind glass which is being there, leading to brain injury, fatal brain injury. So TBI is the leading cause of death, contributing to over 60% of trauma-related deaths. Look at the number, greater than 50%. So what exactly should be your goal or line of approach in management of the TBI? Because of that traumatic brain injury, there is development of inflammation, edema, rise of the intracranial pressure, and CPP, that is the cerebral perfusion pressure, is being disturbed. So your ultimate goal should be stabilization of these parameters, thereby decreasing the incidence of the secondary injury. So TBI may be divided into what? Either into a primary and a secondary injury. Primary injury is caused by the mechanical forces, and it occurs during the moment of the injury. The examples which we discussed. Secondary injury, on the other hand, is not mechanically induced. It may be delayed from the moment of impact. For example, if there has been a beating by any of the siblings or maybe any of the person, so at that moment, the person doesn't deteriorate, but maybe at some point of time, there is a deterioration, delayed impact is being there. So this secondary injury, it may superimpose the injury on a brain already affected by a mechanical injury. So the primary area of insult has been there, but secondary injury has not occurred at that point of time, but maybe sometimes at a later stage, or maybe sometimes due to a delayed phase, the secondary injury occurs, and this may superimpose upon the primary injury which is already being present. Coming to the first, that is the primary injury. So the two main mechanisms that causes the primary injury of this TBI are, the first is the contact, as there is an object that strike the head, like the stick, rod, or any kind of thing, or the brain striking the inside of the skull. So look at that, the brain striking the inside, leading to shaking of the brain, leading to hampering of all the parameters, rising of the intracranial pressure. There is development of infection, inflammation, edema. So it is kind of a shaking movement of the brain because of the contact object striking. The second is the acceleration followed by the deceleration. The example which we told about, if there is a sudden application of the brake, or even if there is a free fall from the, maybe staircase or something, even if trying to, prevent himself rather than falling and going in the event of that falling forward. So acceleration and deceleration are the causes. So primary injury due to this contact, what exactly it will result? It will result to the injury to the skull. There will also fracture of the skull, and along with this, there will be surface abrasions and contusions on the skull, which is being seen or present. So what are these contusions? So contusions are basically swollen brain tissue, typically found on the poles of the frontal lobe. So as we know that frontal, occipital, parietal, and temporal, which are the four lobes of the brain. So this contusion is basically distinct and distinctly seen on the frontal lobes, inferior aspect of the frontal lobes, cortex above and below of the operculum of the sylvian fissures of the brain, along with the lateral and inferior aspects of the temporal lobe. So these are the most common sites of the contusion area due to the injury to the injury or hit by the external forces or external object. So primary injury due to this acceleration and deceleration results for what? Unrestricted movement of the head. Sudden brake going backward, sudden brake going forward, and because of this, it leads to shear tensile and compressive strains on the brain. So because of this forces, acceleration, deceleration forces, there is development of intracranial hematoma or even DAI, that is diffuse axonal injury. Because of this DAI that injures the cranial nerves and the pituitary stalk, thereby leading to compromising of the important functions. Because as we know that hypothalamus and the pituitary are the two important transformers of the brain, a variety of the secretions of the hormone, a variety of the control mechanisms of the body are being regulated through these both organs. So ICH, intracranial hematoma, is the most common cause of death. And because of this only, the patient clinically deteriorates after this TBI. So hematomas can be either epidural due to the fracture of the temporal bone and rupture of the middle meningeal artery. Clotted blood collects between the bone and the dura. So dura is the outermost layer of the brain. We know that dura, arachnoid, and pia, that is the DAP mnemonic which is being there. So there is collection of that blood between the bone and the dura. So it can grow there. If the more and more blood accumulates, it will lead to more and more rise in pressure, thereby compressing the brain tissue. The second hematoma can be subdural due to the rupture of the bridging veins in the subdural space. So they can grow large enough to act as mass lesions. They are associated with higher morbidity and mortality rates. The third is the subarachnoid hematomas that results from damage to the blood vessels in the posterior fossa stalk. So these are the three most common types of hematoma. Coming to the DAI, it is one of the most common and pathologic features of TBI. So what exactly you see? The best way to elicit it or to see whether if DAI has set in or not is to go for a microscopic examination. So the main mechanical force that causes this DI is acceleration, deceleration, rotational acceleration. So rotational acceleration of the brain produces this shear and tensile forces, and you can see a complete pull-off of the axons if you are seeing this on a microscopic level. So if you see this microscopic evaluation of this brain tissue, you will see a lot of detached axons and a lot of swollen axons on the microscopic evaluation. Rapid stretching of the axons. Why? Because of the damaged axonal cytoskeleton, and it disrupts the normal neuronal function, which is the functional unit of the brain. Coming to the secondary injury, this occurs after hours or maybe after days after this inciting traumatic event has set in. So injury results in either impairment or declines in the cerebral blood flow, resulting in hemorrhage, local edema. So as a result of this inadequate perfusion, the cellular air pumping mechanism fails, causing a cascade reactions of intracellular calcium sodium, which lead to more of the cellular destruction. So this occurs after few hours or days. There is excessive release of excitatory amino acids like what? Aspartate, glutamate, failure of the ion pumps to throw it out. And because of this continuing of this cascade, there is generation of free radicals, lipid peroxidation, the cells die, there is proteolysis. So because of all these factors that come into play, this causes what? This causes the neuronal death. So to summarize now the secondary brain injury, these all, signs and symptoms can be elicited in a patient. The patient can develop sudden hypotension, loss of oxygen, fall of oxygen levels, hypoxemia, rise of carbon dioxide, hypercarbia, more body temperature rise, hyperthermia, glucose levels can either rise or fall, hyper or hypo. There will be fall in sodium levels, hyponatremia. It can also trigger seizures along with secondary infection. So these are the secondary brain injury that can result. So now coming to the severity of this head injury, it has been classified into mild, moderate, and severe. So Glasgow Coma Scale is the most commonly used systems for this classifying this TBI. So TBI having a GCS of 13 or above is mild, 9 to 12 is moderate, and everything below 8 is a severe traumatic brain injury. When we talk about the other classification systems that are used to determine severity, duration of this post-traumatic amnesia, patient doesn't recollect the memories, and there is LOC, that is loss of consciousness. So this is the traumatic brain injury based on the GCS, PTA, and the LOC. Mild 13 to 15, moderate 9 to 12, and severe is 3 to 8. PTA less than 1 day is mild, 1 to 7 is moderate, and greater than 7 days is severe. And loss of consciousness for 0 to 30 minutes is mild. Between 30 minutes to 1 day is moderate, and greater than 1 day loss of consciousness is a severe traumatic brain injury. So we have discussed the primary and secondary causes of TBI. Let us go ahead and discuss the symptoms that are dependent on the injury's severity. So the patient may remain conscious or may develop LOC after a few seconds or minutes. So symptoms like headache, vomiting, loss of consciousness, loss of motor coordination, difficulty in balancing, dizziness, ringing sensation in the ears, blurred eyes, fatigue, lethargy, even change in the sleep patterns can be observed. Some other cognitive and emotional symptoms like behavioral or mood changes, there can be development of confusions, trouble with memory, concentration, attention, or thinking can be there. So a person with a moderate or a severe TBI may have a headache that does not go away. So repeated vomiting or nausea, convulsions, and inability to awaken, dilatation of one or both pupils, slurred speech, aphasia, dysarthria, weakness, numbness in the limbs, loss of consciousness, confusion, and restlessness and agitation can be observed. Less common symptoms of moderate to severe TBI includes what? There can be change in the appropriate social behavior. There can be change in the cognitive changes, especially problems with sustained attention, processing speed, and executive injury. So when the pressure rise because of this ICP, that is intracranial pressure too high, it can be deadly. So rising signs of intracranial pressure includes what? There is decreasing level of consciousness. There can be paralysis or weakness on one side of the body. There can be blown pupil or difficult to constrict your pupil in response to light. Heart rate can get slow with a high blood pressure, respiratory depression, and isochoria, unequal pupil size, abnormal posturing. So smaller children with moderate to severe TBI may have some of these symptoms. So other signs that are seen in young children includes what? Persistent crying, inability to console, listlessness, refusal to nurse, eat, or irritability. So how you will now make the diagnosis of TBI based on the neurological examination? Assess the GCS. Neuroimaging is very good in prompt diagnosis and prognosis. So the preferred radiological test in emergency setting is a CT. So if you have CT available, get a CT done as quickly as possible for quick, accurate, and timely diagnosis. So follow-up CT scans may be performed to see whether the injury that has occurred that has been progressed or not. MRI can give more details as compared to the CTs if you have to rule out or look out for DAI. However, MRI is generally not used in the emergency settings. X-ray are still being used again, but if you have CT, go for a CT compared to the X-ray. Angiography to detect any blood vessel pathology, and electroencephalography and transcranial Doppler measurement of the ICP can be used. So if you look at the complications of TBI, post-traumatic seizures, frequently after moderate to severe, immediate seizures occur within first 24 hours, and early within first 2 to 7 days, and late can even occur after 7 days. So prophylactic use of phenytoin is effective during the first week after if TBI has been occurred. So this Tepkin, there was this, researcher, he recommended the discontinuation after 1 week if no seizures develop because of its lack of effect in preventing any late seizures. That is the use of phenytoin. Hydrocephalus, another complication that can occur due to TBI. It can be either a non-communicating or a communicating. Non-communicating, secondary to the obstruction in the ventricular system, and communicating is the most common form after TBI. And it occurs when the obstruction is present in the subarachnoid space, that is between the dura and the arachnoid layer. Deep venous thrombosis, common. You look at the incidence as high as 54%. Because the person is immobile, fracture can be there, paralysis, disruption in coagulation profiles, and fibrinolysis. So DVT, if set in, it can also cause pulmonary thromboembolism. And how you will detect this DVT? Best by venous Doppler ultrasonography and contrast enhanced venography. So as soon as you detect this DVT, if it is being there, even if the patient is immobile, fracture is being there, paralysis being there, do start the prophylaxis with anticoagulants for prevention or acceleration of this DVT. Heterotopic ossification, ectopic bone formation surrounding the tissue. Almost the incidence is close to 11 to 70%. It causes joint pain, decreases range of movements, can be also associated with low-grade fever, warmth, edema, and swelling. So the risk of heterotrophic ossification greatest during first 2 to 3 months after the injury. Spasticity found in almost 25% of the patients. So first line treatment for spasticity is correct the positioning of the involved body segment along with exercises. And second line treatment for spasticity is you can go for a splint, you can apply the cast along with some of the physiotherapies. GIT urinary complications can also occur because of the sequelae. Most frequent GIT complications because of this TBI are stress ulcers, bowel incontinence, dysphagia, and urinary tract complications like urethral strictures, infections, and urinary incontinence can be seen. So post-traumatic agitation is common after TBI. It can get, the patient can get aggressive, the patient can develop depression, the patient can develop insomnia. Post-traumatic headache in almost about 38%, and post-traumatic depression in almost about 40% of the patient is being seen. So initial evaluation, the patients in which you suspect TBI should undergo a rapid primary and secondary survey. You look out for the airway breathing circulation, going back to our ABC approach. So secure whether the airway is being patent or not, adequate oxygenation and ventilation to provide secondary brain injury, because if the patient is unconscious, the patient if develops this, hypoxic brain injury, so you have to make sure that adequate oxygenation and ventilation is being there. So the patient's cervical spine should be immobilized until cervical spine injury is being ruled out. Urgent intubation to secure the patient's airway should be considered in any patients who presents with a GCS less than 8 or in those who are unable to protect their airway. Intravenous access should be rapidly established. So bedside glucose testing should be performed in all unconscious patients, and hypoglycemia rapidly treated if it is being present. So thiamine administration, 100 mg should be administered for the patients who are at risk of nutritional deficiency. If you are suspecting a opioid toxicity, history of illicit drug abuse, apnea, bradypnea, small pupils, administered naloxone 0.4 mg IV should be administered and repeated as necessary up to 4 mg. Appropriate lab tests like serum electrolytes, send CBC with platelets, coagulation studies, ABG, urine analysis should be done. So if a definitive neurosurgical care cannot be provided, Transfer to a higher level of center should be initiated as quickly because there is a golden hour. You have to preserve that. But during the event of this transfer of the patient, you have to make sure that key resuscitative interventions are being initiated till the time the patient has reached a higher tertiary care center. Monitoring is essential, and monitoring through pulse oximetry, ECG, arterial blood pressure, central venous pressure, monitoring of the urinary catheter if the patient has put with nasogastric or orogastric tube has to be done, followed by neurological examination, temperature monitoring, and measuring the end tidal CO2 levels, that is capnography. So resuscitation of blood pressure and oxygen. So what do the guidelines say? If the hypotension or hypoxia, it should be avoided if possible and corrected immediately. Because if you look at the data, hypotension almost occurs in 35% of the patients, and it was associated with twofold increase in mortality. So the whole and sole goal should be to maintain the MAP in the range of 90 mm throughout the patient's course. Maintaining the cerebral perfusion pressure, that is the CPP. So maintaining a MAP greater than 90 and intracranial pressure between 20 to 25. So how you calculate the cerebral perfusion pressure? You make a difference between mean arterial pressure minus intracerebral pressure or intracranial pressure. That gives you cerebral perfusion pressure. So cerebral perfusion pressure should be maintained at a minimum of 70 mm of the Hg. Maintaining of the MAP. So treat hypovolemia. You can give 0.9% IV fluids, NaCl, colloids, fresh fusion plasma, RBCs if the patient is having loss of blood. Avoid glucose containing fluids unless and until there is hypoglycemia. Start enteral feeding. It is better to switch to enteral feeding, as TBI patients may induce hypermetabolic and hypercatabolic, resulting in more loss of energy and protein. Inotropes, if the patient develops hypotension, switch to a inotrope, noradrenaline, dopamine support. So the first priority is complete and rapid physiological resuscitation evaluation. No specific treatment should be directed at intracranial hypertension in the absence of signs of what? Of transtentorial herniation or progressive neurological deficit that is not attributable to a extracranial explanations. So this is the initial management that has to be followed. So indications of ICP monitoring. ICP monitoring is appropriate in severe brain injury, severe head injury, in patients with an abnormal CT or a normal CT scan if two or more of the following are noted on admissions. And what are these parameters? If BP is less than 90, especially systolic BP, age greater than 40, and if the patient is having uni or bilateral motor posturing. So risk of ICH, intracranial hypertension, not hematoma, increased to 60% if two of the parameters were being noted: age greater than 40, SBP less than 90, and motor posturing, which is being there. So monitoring of increase in ICP. CT scan should be done on admission, repeated whenever there is change in symptoms and signs. Frequent neurological examination is essential. Hourly recording of the GCS, hourly recording of the pupil size and reaction, and monitoring of the ICP, if it is being available, has to be done. So ICP monitoring, how you will monitor? In the current state, the ventricular catheter is being there, that is connected to external strain gauge. That is a very good, reliable, low-cost method for monitoring of the ICP. And through that, you can also do a therapeutic drainage of the CSF if it is being necessary to send for examination. So ICP transduction via the fiber optic or strain gauge devices placed in ventricular catheters provide similar benefits but at a higher cost. So ICP treatment threshold guidelines are what? ICP treatment should be initiated at an upper threshold of 20 to 25 mm Hg. Raised ICP leads to a secondary brain injury. And how it is being treated? Treated by osmotherapy, analgesia, sedation, optimal ventilation, surgical, and positioning of the patient. So if we look at the critical pathway which is being there, So critical pathway for the treatment of intracranial hypertension, you insert the ICP monitor, you have to maintain the cerebral perfusion pressure in a range of 70 mm Hg. If intracranial hypertension present, yes, reconsider repeating the CT scan. If no, carefully withdraw the ICP treatment. So if ventricular drainage, if it is being available, go for it. If ICH, intracranial hypertension, yes. Give mannitol 0.25 1 gram per kg IV. Again, ICS. Hyperventilate to maintain a PaCO2 in the range of 30 to 25. ICH, again, repeat a CT or go for hyperventilation to make sure PaCO2, partial pressure of carbon dioxide, is less than 30. Monitor the SaO2 levels, cerebral blood flow pressure accordingly. So this is the treatment pathway for intracranial hypertension in a case of severe head injury of the patient. Osmotherapy with mannitol, it improves the cerebral oxygenation. Mild dehydration after osmotherapy can be desirable. It may improve the cerebral edema, and it decreases the CSF production by up to 50%, leading to prolonged ICP decrease. So guidelines, mannitol is effective for control of the raised ICP. And what is the dose in which you will give mannitol? In a dose of 0.25 to 1 gram per kg of the body. But mannitol has some limitations. Hyperosmolarity is a common thing. Accumulation of the mannitol in the cerebral tissue can lead to rebound phenomena and increase in ICP. So indications prior to ICP monitoring are the signs of if there is transtentorial herniation or progressive neurological deterioration not attributable to the systemic pathology. So the most promising solution as a substitute for mannitol is hypertonic saline. Maintaining a sodium between 145 to 155, you give 250 ml bolus of 3% hypertonic saline through the central venous cannula. Dose is repeated until ICP is controlled or Na level of 155 is being achieved. So this serum Na is maintained at this level until this intracerebral, intracranial pressure is being stabilized and then gradually lowered to normalize. So permeability of the blood-brain barrier to sodium is low. It can produce an osmotic gradient between intravascular and intracellular components. It can lead to shrinkage of the brain tissue. So the selectivity of the BBB to NaCl is more than that of mannitol, making it a potentially more effective osmotic drug compared to mannitol. So hypertonic saline also helps in restoration of the neuronal membrane potential, maintains the blood-brain barrier integrity, and modulates the inflammatory response by what? By reducing the adhesion of the leukocytes to the endothelium. So if ICP control is still problematic after 3 to 4 days, bolus of furosemide are administered in an effort to mobilize the tissue sodium. Serum sodium potassium concentrations are monitored 4-hourly on a blood gas analyzer. So analgesia and sedation, you can use morphine and fentanyl can be used for analgesia, but again should be used with caution because they can cause respiratory depression. Remifentanil in ventilated patients, propofol, especially in the first 48 hours, in a dose not more than 5 mg per kg. And midazolam should replace propofol if there is fear of propofol infusion syndrome. Barbiturates, high dose may be considered in hemodynamically stable patients with a salvable severe head injury with ICH, refractory to the maximal medical and surgical ICP lowering therapy. So barbiturate, high dose barbiturates are used to control ICH. Indications, if it is a potentially survivable head injury, no surgically treatable lesions, ICP greater than 20 to 25, a low GCS, unilateral cerebral hemispheric edema with a significant shift of midline structures. So these are the indications. So goal is maintain ICP less than 20 and see the therapeutic EEG response through burst suppression or cortical electrical silence with preservation of SSEB and BAEFF, that is brain awake auditory echo frequency response. So benefits is promote or induce hypothermia, increase in intracranial glucose, glucagon, decrease in nitrogen excretion, anticonvulsant properties of barbiturates, decrease in excitatory neurotransmitters, and free radicals scavenging is also been done. But there are risks. It can cause direct myocardial depression, direct CNS depression, allergic reaction can occur, and it can increase venous capacitance, or it can also impair gastro or hepatic motility. So dosing regimens, pentobarbital given in a high, mid to low dose And thiopentanol, you give a loading dose of 3 mg per kg bolus, followed by 10 to 20 mg per kg over 1 hour. Maintenance dose of 3 to 3.3 to 5 mg per kg per hour, with maintaining a therapeutic serum levels of 6 to 8.5 mg per hour, and weaning is being done every 12 hours. Monitoring of the cardiovascular has to be done. Cerebrovascular monitoring through ICP, CPP, and EEG, and other monitoring of core body temperatures, barbiturate levels, input-output monitoring has to be done. Therapeutic endpoints and success. What is success? If ICP goes to less than 20 in at least 48 hours, resolution of the compression effects, intracranial mass effect or midline shift, or ICP must remain controlled with conventional therapies. So failure is a diagnosed brain death, uncontrollable ICP, suppression, or intolerable side effects like sepsis, pulmonary dysfunctions can be there. Steroids, use of steroids generally not recommended. Use of methylprednisolone in patients with moderate to severe TBI has been demonstrated to increase mortality, and therefore it is being contraindicated. Mechanical ventilation, especially in patients of hypoxia, hypercarbia, or hypocarbia. Maintain PO2 above 100, SPO2 above 95. Mechanical ventilation should be done if the GCS is close to 8. So monitoring of the PaCO2 levels through the end-tidal CO2 and maintaining PaCO2 levels in the range of 34 to 38 should be done. Hyperventilation. So use of prophylactic hyperventilation, PaCO2 less than 35 during the first 24 hours after severe TBI should be avoided. So hyperventilation may be necessary for brief periods when there is either acute neurological deterioration or intracranial hypertension that is refractory to sedation, paralysis, or CSF drainage. Hyperventilation reduces CSF ICP by causing cerebral vasoconstriction, but aggressive hyperventilation has been used for years in the treatment of elevated ICP, but has demonstrated a delirious outcome. So aggressive hyperventilation should not be followed, especially during the first 24 hours. Neuromuscular blockade may be considered to facilitate endotracheal intubation. Use of neuromuscular blockade may mask seizure activity, increase risk of pneumonia, and it can also cause critical illness neuropathy. So patient should be in a neutral position, head elevation 15 to 30 degrees, application of the neck collar whenever you are suspecting a doubt of cervical injury. So whenever decided by the neurosurgeon, if you are going for a surgical intervention to decrease the ICH, surgery can be performed on mass lesions or to eliminate the objects that has penetrated the brain. Mass lesions are what? That can be contusions or hematomas that has caused a midline shift. So maintenance of the hemodynamic parameters, maintaining a cerebral blood flow, maintaining, clotting time, bleeding time is influenced by what? It is influenced by blood viscosity, which increases by increase in HCT. Use of phenytoin, carbamazepine, phenobarbital, or valproate is generally not recommended for preventing late post-traumatic seizures. Very important. Seizure activity may cause secondary brain damage. So benzodiazepines should be started together with phenytoin. Adequate sedation with propofol reduces seizure activity and raises the seizure threshold. Fever can occur in 30 to 45% of the non-neurologically injured. And in patients, an infectious etiology is always being present in less than 50%, but the remainder is being classified as a central fever. Why? What is central fever? It occurs due to direct damage of the thermoregulatory centers of the brain because of this TBI. So early fever following TBI has been associated with DAI, cerebral edema, hypotension, hypocalcemia, and if it occurs within the first week, it can be associated with increased ICP, neurological impairment, and prolonged ICU stay. So hypothermia is also associated with worse outcomes. Aggressive efforts to control temperature, patients should be implemented, including early intravenous and enteral antipyretic medications, control of room temperature, cooling blankets, and pads. So due to the deleterious effects, therapy should be initiated when the patient temperature exceeds 37 degrees Celsius rather than waiting until the traditional definition of fever has been reached. Traditional hypothermia has been demonstrated to improve neurological outcomes. Data supporting its use following the TBI has been less convincing accordingly. Therapeutic hypothermia may have a role in the treatment of patients with severe TBI and refractory ICP. So therapeutic hypothermia has been initiated. Therapy should be continued until ICP is less than 20 mg, so less than 20 mmHg for 48 hours. Shivering management, shivering management in the context of induced hypothermia is undesirable because it causes patient discomfort, increases the body temperature. It can increase the patient's metabolic demand, and it can also lead to rise in intraocular and intracranial pressure. So maintaining a target temperature management is very much important. Either conventional cooling methods like ice, cold packs, infused cold, peritoneal lavage can be there. And circulation of the water gel pads through the patient's abdomen, thighs. So several intra-cooling systems are being commercially available in the markets, which can be tried. Nutrition guidelines, very much important. 140% of the resting metabolic expenditure is in non-paralyzed patient, and 100% resting metabolic expenditure in paralyzed patient is being there. So there has been trial and prospective trial in 38 patients randomly assigned to TPN and SPN. There were significantly more deaths in the group that did not receive a full caloric replacement by the 7th day after the injury. So proper nutrition supplementation has been done. Urine output maintaining greater than 0.5 to 1 ml per kg per minute. And if you're suspecting a diabetes insipidus, urine output is more than 250 ml per hour. So if confirmed, start with desmopressin. Tiers of therapy, tier 0, 1, 2, and 3. So tier 0, maintain MAP greater than 80 if GCS is less than 8. Maintain MAP greater than 70, administered supplemental oxygen, head elevation, and correct the hyponatremia. Correct coagulopathy, correct hyperthermia, hyperglycemia, prevent DVT, gastrointestinal stress ulceration, and prevent skin blend. Tier 1, secure the airway, secure the breathing. Systemic and cerebral perfusion has to be maintained accordingly, and maintaining or consider the ICP monitoring very much important. Osmolar therapy, which we have already discussed, either a mannitol or a 3% normal IV saline has to be started. Protection of the brain from hypotension, hypoxemia, hypercarbia, hyponatremia, and hyperglycemia according to the standard guidelines has to be done. In tier 2 management, if you have to paralyze the patient, start with rocuronium in a 50 to 50 mg per kg loading dose, then switch to 8 microgram per kg per hour. Mild hypothermia, induce hypothermia with 35 degrees Celsius, and mild hyperventilation can be prevented. In tier 3, surgical decompression, go for a decompressive craniotomy, and hypothermia even to 34 degrees Celsius. And once ICP goes less than 20 for 48 hours, re-warm at a grade not greater than 0.1 Celsius per hour. Barbiturate coma, if not a surgical candidate and refractory to all the above, consider a pentobarbital coma, which we have discussed in the previous. So suggested algorithm, if it is a traumatic brain injury, monitor includes ECG, SaO2, intra-aortic blood pressure, temperature, everything monitor. If GCS is less than 8, switch the patient on mechanical ventilation. Secure the high risk for ICH, ICP monitoring, maintains cerebral perfusion pressure 60 to 70, ICP 20 to 25, intracranial hypertension, sedation and analgesia, volume expansion and inotropes has to be done, osmotic therapy has to be tried, and if it is a persistent intracranial hypertension, hyperventilation, PaCO2 maintaining less than 30 with monitoring of the cerebral oxygenation has to be done. Maintaining serum sodiums in the range of 145 to 155 and alternative osmotherapy with 250 ml, 3% NaCl, and maintaining a serum sodium levels accordingly. So let us discuss a case I have not included basically in this scenario, but just quick because I recall this case that has come to our setup in our clinical scenario. So let us discuss. There was a patient, there was 28-year-old patient. He was a male, he was a worker patient. He developed loss of consciousness and he met with a road traffic accidents, which was done 2 hours ago. So he was brought to our setup in the emergency department due to a motorcycle collision which has occurred, and he was not wearing a helmet. So loss of consciousness that was greater than 10 to 50 minutes. He complained of severe headache. There was drowsiness. There was no history of seizures till far. Past history, there was no elicited past, brain injury, head injury, or any known comorbidities in the patient. No significant drug history was also present, but the personal history of alcohol use was present in our patient. So we did a primary survey of airway, breathing, circulation, airway, breathing was, respiratory rate was on the higher side. He was tachypneic. Oxygen saturation levels were still 94, 95. Pulse rate was a bit higher, almost tachycardic. BP was high on the higher side, 150, 90. A GCS was evaluated 9/15. So secondary survey, there was signs of raised intracranial pressure. The patient has headache. The patient had vomiting. The patient has altered sensorium. So we made a provisional diagnosis of moderate to severe traumatic brain injury with suspected intracranial hemorrhage. We sent all the routine coagulation profiles. We did the ABG. We gone for a CT, NC-CT, and it showed, even a midline shift. It showed an epidural hematoma. So our final diagnosis, which was being confirmed through this, after this NC-CT, was a traumatic brain injury, which was severe. There was epidural hematoma with raised intracranial pressure. So we put the patient on mechanical ventilator. We secure his airway. We secure the IV lines to maintain a SBP greater than 100 and cerebral perfusion pressure greater than 60. We followed the ICP control measures. We started the patient on Mannitol in a dose of somewhere between 0.5 gram per kg body weight. Accordingly, as there was development of epidural hematoma, we had to involve the neurosurgeon, and there was emergency craniotomy which was being done, and evacuation of the epidural hematoma was being done. So post-operative, the patient was being shifted to the neuro ICU. Continuous neurological monitoring was done. We repeated the CT after 24 hours. We started the patient on seizure prophylaxis. Nutritional feeds were given through the enteral feeds, and the patient has a good prognosis because on the subsequent CT. So this, with the proper approach of any of the traumatic brain injury patient, you can definitely, adapt this management. So because early intervention, early diagnosis saves lives. So if it is a good prognosis, if and only if this evacuation or timely interventions has been done, if there is a delay, that can lead to what? That can lead to brain herniation. That can lead to even death of the patient. So accordingly, proper monitoring has to be done. So tier 1, tier 0, 2, and these 3 therapies, tier 0, 1, 2, and 3 therapies is important. You can definitely go for it. Shivering management, control of all the, seizure prophylaxis, hypothermia, putting the patient on mechanical ventilator, use of analgesia, sedations, when to give, osmolytic therapy, either with 3% NaCl or Mannitol, controlling or maintaining of the ICP, what is the range of ICP, what is the range of CPP has to be done, and how accordingly you manage the complications, how you will classify the brain injury, what is the primary brain injury, what is the secondary brain injury.